Hi, I'm Dr. Leonard Calabrese from the R.J. Fasenmyer Center for Clinical Immunology in the Department of Rheumatic and Immunologic Diseases at the Cleveland Clinic. I'm here with my colleague Elaine Husni, and I want to welcome you to Rheumatology Highlights Report Best Practices. Today we're going to drill into EULAR and some of the interesting data that's come out from there. We're going to be talking about RA, treatment and monitoring, and we have a lot to talk about, so let's get into it. The first study is the RACAT study. This is Jim Odell and his fine functioning network that have made already significant contributions to clinical trials. So the question is, what to do with methotrexate failures? Do we go to biologics? Do we do combination DMARDs? This is a practical and important question to rheumatologists. So the RACAT study was a double-blind, randomized controlled trial, 48 weeks, 350 plus patients, and they were randomized to two limbs. Traditional triple therapy or methotrexate plus Etanercept. And the primary endpoint was DAS28 at the end of the study. So if you looked at the study group, they had disease about 5 years, typical 57 years of age, moderate DAS 4.4, and they had all been on methotrexate at least 12 weeks. These two graphs really summarize the results of the study. And what this shows on the top is the overall response, and then you also see the effects of the rescue limb. And you don't have to be a statistician to look at this graph and see that in terms of DAS response, the changes between these two limbs of the study were really not clinically significant or statistically significant, in fact met the non-inferiority benchmark that they had set. Now, there were a variety of secondary outcomes, and these are really important in this kind of study because people say, well, they're clinically equivalent, but. So when you looked at some of the breakdown markers of pain, quality of life, adverse events, no difference. But what about radiographic progression? Well, here the differences were minute, only about 0.25 sharp points over a year. This is really pretty small. In some of the extreme endpoints, ACR 50 and 70s, there was an advantage, numerical advantage to the TNF at 24 weeks, but not at 48 weeks. What's the significance of this? This study has actually been published after the meeting in the New England Journal. And there's a very nice editorial by Joan Bathon and McMahon. And they make a couple points. First of all, there are other studies that have looked at this. The TIER trial, while clearly a different design, looked at the differences in sequencing these drugs from the beginning, and SWIFOT, which took methotrexate IR patients and randomized them to an infliximab versus a combination DMARD regimen. Both of these studies showed that they're fairly comparable, but SWIFOT had difference in radiographic outcome that was more impressive than this, almost 1 sharp point at 1 year. So Joan in her editorial said, maybe the results of these studies are just too late, that people now, when you fail methotrexate, go to a biologic. So now let's turn and kind of ask the question, what are the best practices that you get out of this? Does this change your practice? Does this mean that triple therapy is better for initial therapy or the methotrexate IR?
I think these are great questions. One of the first things I think about is when somebody's on methotrexate, are they taking it, have we optimized it? So those are one of the things I look at, whether it's an oral route, whether I need to change to a sub-Q route. So I think that's important. How high I'm going on the methotrexate dose, I think, we have a lot of ability to switch our methotrexate, change our route of administration. I think that needs to be maximized before we look at this.
I interrupt you, but it was interesting. They used, significant doses of methotrexate, but they really didn't optimize. There was no algorithm to go to sub-Q, and this is a very hot area now. So that's a good point.
Yeah. So the other thing that I wanted to talk to you about is just, how compelling is this radiographic data? So to me, it's just really hard to transmit sharp scores into my clinical practice. And so A, as a rheumatologist, we want to make our patients feel better. And then B, we want to prevent them from long-term disability.
In the same vein, the sharp score impact is something that everyone talks about. 0.25 difference is clinically trivial. And I think that some people have said, well, tear was one sharp point and it was over, a period of time, that what if you follow and that difference grows? Well, only time will tell, but to me, this has made me pause and think that triple therapy is pretty darn good. So,
yeah, I agree. I have to admit that because I live in an era where biologics came right when I started rheumatology fellowship, that was really the go-to place. So triple therapy wasn't even
well, for us old people, it's
didn't mean it that way.
Made me think about it differently. Let's go to something else. I just want to take a brief minute on this because this is really preliminary. Joseph Smolin had a very crowded room to discuss the EULAR updated guidelines. And there are a couple points in here I think that are dovetail nicely with the RACAT study. First of all, most of the old studies and recommendations are the same. Diagnose early, treat the target, methotrexate. Pick a target of low disease activity or remission. Where it did differ is that they are unequivocal in this and saying that all patients with rheumatoid arthritis, no matter how active or what prognosis that they may have, that non-biologic DMARDs are the initial treatments of choice. Now, this diverges with the ACR that says under circumstances with markers of poor prognosis and high disease activity, you could go to a biologic first. And they say that they are going to recommend, if these hold up, only non-biologic DMARDs first. And then the second thing that's different is that they say that when you do switch to a biologic because the first regimen is failing, that any biologic can be used, not just a TNF inhibitor, so tocilizumab or rituximab or abatacept, et cetera. Then lastly, they have some language in there for tofacitinib, which, as many people know, is not approved in Europe for biologic failures. So, as I said, this is going to be vetted, and it may or may not be the same, but what do you think of this? So is methotrexate-based therapies your initial drug of choice, and do you differentiate biologics going forward for failures?
I think, guidelines are good because it helps me organize my thoughts now that we have so many tools in our toolbox. But I think the reality is that patients also come with many comorbidities, and sometimes that drives the decision. So I think algorithms, guidelines are great. They allow me to think in a more productive way, but when it comes down to my patient and I probably have to look at comorbidities as well as a very important part of this.
To me, I think that's the linchpin of this, particularly for the biologics, because, TNF inhibitor has been around for 15 years. They're my initial go-to drug. But, you're looking at people, that maybe they have a little more anemia and inflammation. You may want to go to the IL-6, or they're intensely, rheumatoid factor positive. You may want to B-cell deplete, or, the more modest safety signal of ABA might influence you for some comorbidity. So I don't want to, we'll revisit these again when they're for real. So the last thing I want to talk about is, what's the T in the T to T? What's the target? We have lots of targets to talk about. Could be a clinical target that is a questionnaire based, like RAPID, or it could be the DAS or the CDI or SDI. We are now in an era where we have over and above these patient-reported and doctor-driven metrics. And there are a couple things that are on the table. The first is that there is a very interesting paper, and this was actually discussed in abstract form, the EULAR recommendations for the use of imaging of the joints in clinical management of RA. Now, I recommend everybody read this who's interested in ultrasonography and MR, and I'm not going to spend much time on it other than to say that it's very cautiously written, and it points out a lot of things, that, that these techniques are more sensitive and more precise than our physical exam, but at the end of the day, they say that we acknowledge there is still a large amount of research required to optimize the use of imaging tools in routine clinical practice. In particular, which joint should be used for the disease assessment and monitoring, and consideration of the feasibility, including costs, appropriate training required to use ultrasound and MR in clinical practice. So Elaine, in the United States, are these things ready for prime time?
I am leaning towards more imaging. I think it not only helps me, but it also allows me to speak with my patients with some more objective measures. So it's been helpful.
Okay, so I think that having said that, and people speak with their feet, and there's a lot of it being done, a lot of high quality imaging around. Where it fits in the cost-effective algorithmic approach remains to be seen. So lastly, let's talk about biomarkers. There are two sets of studies I'd like to talk about. The first is 1433 ADA. This is a commercially available test that can be obtained in the United States right now. And I've learned a lot about 1433 ADA. I always thought this was just Jakob Creutzfeldt, but these are intracellular pivotal proteins that bind to phosphatidylserine, phosphatidyltyrosine, and they can affect all types of pathways of immune activation, proliferation, cell death, and cycling. And as it turns out, one of the 7 isoforms, 1433 ADA, is selectively produced in rheumatoids. And they've compared this to psoriasis and IBD and gout and other inflammatory diseases. And so it's been marketed largely as a test that if you add it to CCP and rheumatoid factor, increases the diagnostic specificity. The question at the present time is this allowing a better monitoring? And there are some data that were presented to show that this is a very good biomarker. Let me just, actually, let me save my question for the end. Let's talk about the next biomarker, and then we'll go through. So, multiple biomarker disease activity. This is marketed under the label of Vectra. It's a widely available test in the United States, and a lot of people are uncertain as to what this means. The test is interesting because it was developed in an agnostic fashion. They took a well-defined patient population, looked at hundreds of putative markers of biologic activity, and came down with this handful of markers that they have cast into a low, medium, high disease activity. Rheumatologists look at these tests and say, does this add anything to my exam? I mean, do I add an expensive test? Does this help my patient? So the Leiden Early Arthritis Clinic is really pretty remarkable. They recruit patients from all over the country. They get these patients with disease for just a few weeks. And they've done a lot of different therapeutic trials, and they've followed them for a number of years. So this company got access to the samples and correlated them with clinical markers that are used and relied upon heavily, and asked the question, which may be a better predictor of radiographic outcome? And here, the benchmark on the y-axis is people that have progressed greater than 3 sharp points. So this is in 0.25. This is a little bit more. I think everybody would say that is a significant amount of progression. And what you're looking at in this graph are patients in the different colors who have had a low, moderate, or high multiple biomarker disease activity readout. And on the bottom, these were the DAS scores. So low DAS at target, moderate DAS, and high DAS. And if you look at this at the extreme, so this is really looking at the outliers, even in the low DAS, which may be an acceptable target, 44% of those patients who had a high MBDA radiographically progressed. That is an outlier to me, and that's kind of interesting, and we'll come back to it. If we take the test that all rheumatologists do, and this is CRP, and this is at a 1.0 cutoff, the differences are even more marked. And that you can see that patients are radiographically progressing 50% in the high multiple disease activity marker group who had low CRP. So these would be people we'd be feeling pretty good about, are radiographically progressing. So I guess at the present time, the final question is, do any of these markers tweak your interest? Are they affecting your practice?
So I must say the more recent data looking at radiographic progression is very interesting, more compelling. These are all still retrospective studies, so we would love to see prospective studies looking at biomarkers. For me in practice, I'm not sure I'd be ready to use this every day with every patient, but in discordant patients, I think there is a role that I'm beginning to use them more.
It's very interesting. Elaine and I practice. She's downstairs, I'm upstairs, and we have shared a number of patients over the past month where we've done the multiple biomarker disease activity and trying to figure out where it's added. And I must say, a couple of these patients, I've been surprised, and it's made me rethink this. I think I look to get some more experience and see more of this type of data moving forward.
I think I'd like more data.
Okay. Well, that's the wrap for Rheumatology Highlights Report for RA. We have another one for Spondy. Come and visit us. Hi, I'm Dr. Leonard Calabrese from the R.J. Fasenmyer Center for Clinical Immunology and the Department of Rheumatic and Immunologic Diseases at the Cleveland Clinic. I'm here with my colleague, Elaine Husni, and this is Rheumatology Highlights Report Best Practices. We're drilling into the data that came out in and around EULAR, and this installment is on psoriatic arthritis and ankylosing spondylitis. This is an area of great expertise for Elaine, so I'm going to let her drive.
Thanks, Len. As you know, I'm very interested in psoriatic arthritis and now more so in spondyloarthropathies. So before I begin looking at all the EULAR abstracts, I wanted to take a look at the Caspar criteria. As you know, this has really changed our world in psoriatic arthritis. It's really allowed us to classify and define this case definition. So I just want to remind you of the Caspar criteria. Also want to remind you that family history can get you 1 point on this, so we're trying to diagnose this earlier and earlier. So I'm going to go look at the EULAR abstracts in a little more detail. So we're going to go beyond TNFs because what has been highlighted at this meeting is that not all patients with psoriatic arthritis respond to TNF, and there are 3 new mechanisms of action that I'll review. First is the P2 Summit trial. That's on ustekinumab. It's already approved for psoriasis in 2009. Look, it is an IL-12/23 inhibitor. In this phase 3 trial, we see here about 300 patients, so pretty good trial, looking at both TNF naive and TNF treated patients and ustekinumab at 2 different doses, as you can see here, compared to placebo. And the results are basically in terms of ACR20 that it's met. It's about 43% met ACR20 compared to 20% placebo. And this lasted for 52 weeks, so for about a year. So the implications are this shows some promise in PSA. It's one of the furthest along in terms of newer mechanisms, different from TNF. And the challenge is it as effective for the joints as the skin? And are there any safety concerns?
Well, you know, to me, I think that this is a drug that we know is hands down highly effective for skin and has beat the TNF in head-to-head trial. Mm-hmm. You know, there's this little lingering cardiovascular risk that's been thrown out there in one of the large trials here. There were 3 cardiovascular events. How do you think that's playing out?
So it's interesting because in the pivotal trials for ustekinumab, there were all these events in the treated group, ustekinumab, and 0 in the placebo group, and that's what highlighted this. But then when they looked back at, looking at other psoriatic arthritis trials, Crohn's trials with ustekinumab, we didn't really see that cardiovascular signal. So
I'd like to see a head-to-head with a TNF.
I think that's where we're going next. Next mechanism of action is Apremilast. This is an oral small molecule. So now we're talking about intracellular mechanism, so breaking down cyclic AMP. So this is a rather large trial. We're talking about 500 patients here in the PALACE 3 trial. This was presented at EULAR with Dr. Meese's team. And it looked at Apremilast at 2 different doses against placebo. And these are active PSA patients despite on DMARD treatment. So as you can see here, they met their ACR 20 endpoint in 16 and 24 weeks. So Apremilast does improve the signs and symptoms. What's really interesting is that whether it's monotherapy or in combination with a DMARD, that it does reach some ACR 20 significance. Brodalumab is a novel IL-17 inhibitor. This is a monoclonal antibody that's come up in just a phase 2, so we're talking about a lot smaller trial here. We're only talking about 160 patients or so. Also looks promising, ACR20 early results at 12 weeks and 24 weeks, also showing some response to PSA. So I guess overall, we have now new mechanisms of actions that are available, possibly to us pretty soon. So how does this change our treatment paradigm for psoriatic arthritis?
You know, Apremilast is an interesting drug. You know, the whole class of PDF inhibitors has been plagued by side effects. And this does have some significant side effects, but they're mostly nuisance side effects. And I think people that tolerate it well. There were no big safety signals in that study. And, you know, to me, that might be an inviting drug for people with modest disease. Doesn't require a lot of laboratory monitoring. And if they tolerate it, you know, intent to treat it might be good. The IL-17 story, you know, I'm kind of agnostic about it. It's been so disappointing in rheumatoid arthritis, yet it shows us these are not the same diseases, and which we know already. And, you know, how this is going to stack up against the standard bearer of TNF, I'm not sure.
All right. It's a very exciting time for PSA. As you know, it's largely been borrowed by RA and, you know, not as many treatment regimens. But, you know, looking at intending EULAR, you see a lot out there, a lot to look forward to. So let's focus our attention to ankylosing spondylitis. As you know, this is an iconic slide looking at some advanced changes, many of which we can't even show or teach our trainees anymore because we don't see ankylosing spondylitis at these end stages. So I just wanted to refer quickly to the ASAS classification criteria. This is one of the newer criteria that's out now. And really, the purpose of some of these criteria is really trying to get earlier to these patients with ankylosing spondylitis. So this particular criteria does not absolutely require radiographic evidence to diagnose you with a spondyloarthritis. So in your office visit, what do we look at? So we look at, of course, at symptoms. We see what the patient has, inflammatory back pain being the prototypical thing that we look for. Unfortunately, as you know, its definition and its ability to tease out in patients can be sometimes difficult from mechanical back pain. We also look at imaging very commonly, and then, of course, our elevation in sed-rate or CRP is also important. We also want to see past history. We want to see what their response is to NSAIDs, what their family history, genetic testing, and of course we know these very common concomitant diseases that help clue us in: reactive arthritis, psoriatic arthritis, as well as association with IBD arthropathy. So I'm going to, this is a little busy slide, but what I wanted to highlight is that the ASAS criteria that I just reviewed really goes from one end to the other end of the slide, meaning it goes all the way from early diagnosis to the late stage findings as well, while the New York modified criteria, you really needed radiographic evidence. So we're going to focus on the non-radiographic stage. So in EULAR, there was a lot that came out regarding this. So we're going to go over some of the abstracts. The effect of adalimumab. This is probably the longest trial, so we're looking at 2 years in non-radiographic, and this was a post hoc analysis done on 107 patients that had positive MRI findings, not radiographic findings, and an elevation in CRP. As you can see here, in terms of almost half, or 49%, was reaching some remission rate for ankylosing spondylitis, and 82 and 66% for ASAS 20 and 40. Then we looked at certolizumab for both ankylosing spondylitis as well as non-radiographic axial spondylitis. This was a shorter trial. We're only looking at 24 weeks, placebo-controlled, very similar results between AS and non-radiographic, but most importantly, there was some results compared to placebo. Here, I just wanted to point out they saw changes within about a week, so some improvement within a week with no safety signals. The last abstract I wanted to discuss is Etanercept, also looking at non-radiographic. This was only a 12-week trial, but it met its primary outcome, ASAS of 40. Etanercept was shown to be more effective than placebo, with decreasing both disease activity as well as MRI inflammatory changes. So here we have you know, this non-radiographic concept, sort of the old versus the new classification criteria. We have you know, issues regarding what happens if we have a little bit of a diagnostic delay. Is there something that's going to happen bad later? And then I think we discussed also about the FDA voting that came out after EULAR.
Well, I'm not like Elaine. I'm not an ankylosing spondylitis expert, but I'm kind of like the everyday man rheumatologist here in this. And I've taken care of a lot of ankylosing spondylitis. And I will say this. I believe in this, this paradigm very much. And I have, in the past few years, diagnosed a number of patients who were referred to me by rheumatologists who were confused as to the presentation of aches and pains. I've seen this diagnosis, everything from polymyalgia rheumatica to who knows what, and they have made excellent responses. So I'm looking for more non-radiographic. Second thing is I learned at EULAR that MRI, you'd think that this would be extraordinarily sensitive, and the sensitivity is very modest in this disease group. At the same time, I read the FDA hearings where the results were very mixed. The adalimumab effort was shot down by 12 to 1.
12 to 1,
And because they said that the patient population was not really well defined. And when they went back and looked with central reading, that many of these patients had radiographic AS. And they did. So I think there's still a difficulty in defining this. Certolizumab was approved, but at a fairly close margin. And I think many of the people in the committee just didn't believe this, and I do believe it. I think that we need a more refined algorithm, but I think this is here to stay, and this is going to be very important for primary care physicians to learn who to refer. That's where I think it's at.
Right, and I think, in reading some of the FDA documents, it seems that the concern was just that uncertainty of how to really diagnose or define non-radiographic versus the mechanical back pain. So I think we all are in agreement that if they have non-radiographic and they have inflammatory back pain, that this is the way to go. The question is, should we or should the FDA approve this all out? So lots to look at moving forward. So I just wanted to also highlight from Nature's Review Rheumatology. I thought this was very interesting in looking at the pathophysiology. So if you look at inflammation that starts at the corner of the vertebrae, you see that second slide there, second pictorial. Then if you look at the third and fourth, you notice that there's erosive changes. There's also bony proliferation leading to syndesmophytes. And interestingly, as you know, these are uncoupled, right? So TNF and NSAIDs are not, they're really doing two different things in this disease. So the question becomes, does prolonged NSAIDs, make a difference? What are we doing nowadays with this if we're adding a TNF? And what are some of the long-term data? I mean, I could start with telling you that the long-term data looks really good. And for me, the conundrum is, what do I do with the anti-inflammatory?
I would say that to me, there's no doubt that NSAIDs are hugely important, and it's very interesting. You showed that iconic photograph of the humped over guy like that. You don't see those patients anymore. And that was, I think, the results of telling people to exercise. That was the mantra when I was in training, and aggressive use of NSAIDs. Now we're looking at the immune-bone interface. We're finding out the IL-23 and more novel pathways are involved. So I think the prospects are very bright.
Great. So speaking of exercise, so I have to tell you that in my training, I don't think exercise has really been emphasized, but this interesting abstract I just wanted to pull up, I just looked at 60 patients, 30 randomized to exercise and 30 to no exercise, and they actually showed some great improvement with muscle strength and also 6-minute walk tests. So I think this kind of just adds to what you just said, that exercise that helps with flexibility are really the most helpful for these patients.
Well, Elaine, thank you so much. I think that the spondyloarthropathies and psoriatic arthritis are a rich area. We're going to see a lot more coming down the pike. I want to invite you back to our other RHR best practices on rheumatoid arthritis, and come back to the website. Biologics 5 is now posted. We have so many great talks and presentations by some of the world leaders in biologic therapy. Visit us often. Thank you.
Thank you.